Welcome back to Season 3 of The Verdict. I'm your host, Tammie Smeltz, Content Marketing Manager with Milmick Insurance Company. This year, Milmick is celebrating our 50th anniversary. We are grateful for the opportunity to be of service to the New York healthcare community for half a century, and we look forward to providing service like no other for years to come. Before we delve into today's episode, I wanted to extend a huge thank you to all of you, our listeners. We wouldn't be here without you. My guest today is Dr. Salvatore Volpe, who will share his wealth of knowledge on treating the LGBTQ plus population. Good morning, Dr. Volpe. Thank you for being a guest today on The Verdict.
Good morning, Tammie. Pleased to be here.
I'm so excited to have you back as a guest. I can't remember if this is your third or your fourth time on our podcast, but we always enjoy having you as a guest. And today's topic is something that is very important to not only physicians in New York State, but also the entire country and world. And I know this is a topic that is close to both of our hearts. So I'm really excited to hear what you have to share about the LGBTQ plus community. Now, as we know, creating a welcoming space for the LGBTQ plus community is very important. What suggestions do you have for a medical office practice? Are there any specific signs or flyers or things that should be visible in the waiting room?
I'll begin with some stories because that's how I usually like to talk about topics. So the first thing I'd like to mention was, as an adolescent, I belonged to several book clubs, and one of the books I ordered was entitled Subliminal Seduction. And I guess at the time, I thought it was going to give me dating tips. But actually, it was a book that revealed how Wall Street, by engaging different senses in an individual, could make people be more interested in something or less interested in something, whether it was a sight, a sound, etc. To bring the idea closer to home, just think about when you visited your mom's house or Nonna's house. And for me, Nonna means grandma in Italian. And when you walked in, pretty soon you probably saw photos of people that looked like you. And they could have been, again, your parents, your grandparents, aunts, uncles, cousins, and maybe the photo that you thought had hopefully been displaced of an awkward teenager that looked like you. And the key thing is something that made you feel comfortable when you went into those homes. Well, you want to do something similar to that with your website, social media, and actual physical practice. So when we talk about website and social media, you want to include inclusive imagery, such as same-sex couples and rainbow flags. So if you got to see a picture where I'm sitting right now, you'd see that in my home office, I've got imagery that's consistent with what we're talking about. You want to include inclusive text, for example, using pronouns of they instead of he or she. You want to include links to useful LGBTQ sites that are either health-related or maybe even organizations that are supportive of the community. You want to ensure that all your online and in-office intake forms have been updated to include SOGI options. So what's SOGI? SOGI stands for sexual orientation and gender identity. So options consistent with SOGI would fall under the categories of having the right pronouns, including gender expression options, options regarding partners, sex assigned at birth, whether gender-affirming intervention had occurred, or whether it was even planned. You also want to consider adding these terms of sexual orientation, gender identity, and gender expression to your employment and patient non-discrimination policies. In the waiting room, it's, again, pretty much the same sort of idea of having imagery that's consistent. So imagery of same-sex couples, rainbow flags, the use of inclusive text in all your literature, having printed materials that are helpful and useful to the LGBTQ plus community, which could be health-related sites, could be organizations, as we previously mentioned. And again, all forms consistent with SOGI. You also want to think about having including options related to transgender, so female to male, male to female. You also want to have unisex bathrooms or access to bathrooms that's consistent with a person's gender identity. You should be cognizant that there are community-based organizations that can provide training with a focus on person-centered care, as well as the LGBTQ community for you and your staff. And it's something that we encourage you do and share with others. Your local social care network, for those of you who are in New York State, you would know that we have Medicaid redesigned, the 1115 waiver, and that there are social care networks throughout the state which support community-based organizations, and these community-based organizations would have resources for your staff as well as for your patients.
Okay, great. So that makes a lot of sense. People want to read text or read language and see images that they resonate with or that make them feel included. So that makes a lot of sense, Dr. Volpe. Now, I know we talked about some terms like the use of pronouns. Are there any terms or phrases that healthcare providers should avoid when they're treating this group of patients? Is there anything that they could say that would maybe make the patient feel not inclusive or not trust their provider?
Sure. I'll include some of the terms that you don't want to use, but also give you a short list. And in the references that we'll be including with the podcast, there's a rather extensive list of terms that you should use. But as I previously mentioned, the use of he and she as opposed to they would not be something that people would find welcoming. And the idea that there's only two sexual identities, binary, is something that, again, would not be welcoming for this particular community. So I'll go through some terms so you can see what I mean. So the idea of binary. Binary means that there's only two identities, female woman, male man. This is often erroneously used to discuss issues of sex and gender in the dominant society. So in this case, if you were talking about life partners, instead of just saying wife or husband, you could use the word partner, which is more inclusive. Another term to understand is cisgender, having a gender identity which is congruent with what is traditionally expected based on the sex assigned at birth. The word gay, it's a term used to describe a boy or a man who's attracted to boys or men. It's also used as an umbrella term to describe people of other gender identities with same gender attractions and relationships. Gender identity. It's a person's internal sense of gender, which could be male or female. Gender expression, again, not the same as gender identity per se. Gender expression is a person's external presentation, appearance, and behavior. Lesbian, a term that's used to describe a girl or woman who's attracted to girls and women, regardless of their sex assigned at birth. Some non-binary and gender diverse people, regardless of the sex assigned at birth, also use this term to refer to their same-sex attractions. Sex assigned at birth. This is a term that's usually based on a phenotypical, anatomical presentation of the infant to categorize them as either male, female, or intersex. Transgender or trans. This is an umbrella term to describe a broad diversity of people whose gender identity is incongruent with the sex assigned at birth.
Great, thank you for that. And as you said earlier, we are going to provide a number of links and references in the notes for the podcast so people will be able to access this information easily. Now, let's move on a little bit from the office environment and vocabulary, and let's talk about the actual visit with the patient. I know you want to gather necessary information without making assumptions or causing any discomfort to the patient. What are some important questions that you would ask a patient as part of their health history? And also, is there questions that you should be mindful of when you're asking them?
Very good question. So one of the things you want to think about is just how you introduce yourself. So you might say, hi, my name is Dr. Sal Volpe. How would you like me to address you? What pronouns should I use when referring to you? If the stated name of the patient differs from that which is in the chart, would you like us to include the name that's in your health record or some other name? When initiating a sexual history, you might want to say, I'd like to talk to you for a few minutes about your sexuality and sexual health. Emphasize that you ask all your patients these questions, as sexual health is important to one's overall health. And ask, is that okay with you? The idea of preferences. Are there any terms that you use to describe your body or intimate experiences that you would like me to use? I want to make sure that we are on the same page when we're talking. If the patient uses a previously undefined term for their body, you might want to ask, I just want to clarify, when you say X, are you referring to Y? You know, one of the things that you'll find as you're interacting with individuals, regardless of their orientation, is that there may be some terms, there may be some vernacular that's being used by them and their community that you're not familiar with. And this is an opportunity for you to learn it, not just for your interaction with this individual that's in front of you, but for the next individual that comes that could have a similar history. When you're talking about partners, you might ask, are you having sex with anyone? Open-ended question. Tell me about your partners. If the patient's sexually active, you might want to ask, what are the genders of your partners? You should also talk about contraception if it makes sense. You want to talk about contraception and fertility planning. Do you use any forms of protection during sex? If not, why not? What is your history with screening for sexually transmitted infections? You need to know, has the patient been screened in the past and what those results might be. Do you or your partner or partners have any plans around becoming pregnant? It's very important to talk about partner violence. Do you feel safe with your partner or partners? Do you feel comfortable with the sexual experiences that you have? Do you ever feel forced or coerced into doing sexual things you don't want to do? And another important option is talk about the goals of care. Again, this is something we would do with all our patients. Who is involved in your medical care? What does your social community look like? Are you in any need of support outside your local support group for your health care? Is there anyone who should or should not know about what we discussed today? Again, I'm sure this is resonant with most of the practices that we do for all our patients, but some of this may be unique for this particular population. Another thing that would come up in the history is something that actually my son, who is a published author on these topics, created, and it's called an organ inventory. And so we need to be cognizant that individuals may be in process, having had or in the process of receiving gender-affirming procedures. So you would ask about a natal vagina versus a neovagina. Have you had any organs removed? Have you had any transplants or prosthetics, as in the case of a neoscrotum? So these are the types of things that usually may not appear on our usual history intake form, but it's very important, not just from a sexual point of view, but also to know if a person had their appendix or gallbladder removed in the past and we're sending them for imagery of their abdomen, it's important to notify the radiologist of what is not there anymore, so that when they're looking at the image, They're not making presumptions that they're looking at a gallbladder that was removed 15 years ago, or ovaries that were removed, or a uterus that was removed. So an organ inventory is, I think, a very intelligent thing that we should do for all our practices, but certainly for a population that has had gender-affirming procedures.
Okay, thanks for all that, Dr. Volpe. I'm going to say that that was a lot of information, and that it is important to get a very accurate and detailed history when you are treating this patient population. When you're going through the history, are there any specific mental health concerns that you would worry about?
Yes, and this is hypercritical for all populations, and especially this particular population. So as primary care providers, whether we're internists, family medicine providers, pediatricians, gynecologists, we should be aware that the integration of behavioral health with physical health improves outcomes overall. And a very important topic that we need to be keeping at the forefront is the topic of suicide. Suicide most often occurs when stressors and health issues converge to create an experience of hopelessness and despair. For the LGBTQ plus population, stigma, prejudice, and discrimination increases the likelihood of such stress, depression, and mental health concerns. Conditions like depression, anxiety, substance use problems, especially when unaddressed or when people lack access to quality mental health care, can increase the risk of suicide. I want to share some very sad statistics. You should know that LGBTQ plus teens are 6 times more likely to experience these symptoms of depression than the general population. 39% of young LGBTQ people have considered suicide in the past year. 39%. That goes up to 46% if they are transgender or non-binary young children. So almost 50% of transgenders have considered suicide in the past 12 months. Overall, more than 1 in 10 LGBTQ people have attempted suicide. Nearly half of this population as youth experience bullying, which, as you can imagine, is a great source of stress. So we talked about some of the factors. I just want to maybe reiterate them for you. Social isolation, low self-esteem, substance abuse, depression, anxiety, and other mental health issues often result in a sense of stigma and discrimination. Experiences of prejudice and discrimination include family rejection, the aforementioned bullying, cyberbullying. Again, gotten a lot of discussion over the past few years. When I was growing up, the bullies kind of were on the other side of my house door. You could close your door and that would be the end of it. If they called your home, your mom and dad would probably pick up the phone, say some interesting things in the language of their grandparents, and hang up, and then maybe not pick up again. But with the use of social media and the ever-present cell phone, it's almost impossible for children to escape cyberbullying. So it's important to keep that in mind. Laws and public policies that encourage stigma and discrimination, as well as the lack of laws and policies that protect against discrimination, is a factor. But there are some factors that can reduce this likelihood of suicide attempts and suicide deaths and actually promote the well-being. Increasing family acceptance and affirmation of one's LGBTQ identity. Reducing the stigma, reducing the prejudice, reducing the bullying and other forms of victimization. Increasing access to LGBTQ affirming physical and mental health care. Increasing legal protections from discrimination all play a role in promoting the well-being of this particular community. The other thing you should know is that some recent trials that suggest that testosterone therapy significantly reduces the risk of gender dysphoria, depression, and suicidality in transgender and gender diverse individuals desiring testosterone therapy.
All right. Well, thank you for sharing all of that information. Those are really some grim statistics for the LGBTQ plus population. So we talked about the health history, and then we talked about the mental health concerns when gathering the health history. What about the physical exam? Would the physical exam differ from LGBTQ patient as opposed to just, you know, a well visit for a young adult?
So, as we mentioned, the history would come before the physical. So, again, you do that inventory, that organ inventory, and that also includes medication history. So, if an individual is taking hormonal therapy, that's going to change their appearance, right? So patients receiving affirming hormone therapy, can present with a broad spectrum of physical characteristics depending on the duration of the therapy. Some of these findings conclude androgenic alopecia, androgenic acne. If it's estrogenic supplementation, there could be a feminine fat redistribution and a decrease in testicular size. The other thing that happens in trans men is by using testosterone, it's going to lead to atrophy of the vaginal tissue that's present. This atrophy of the vaginal tissue can make pap smears more difficult. So you may want to consider using a pediatric speculum as opposed to an adult speculum. You may want to talk to their other providers, if there are other providers, about maybe pacing the testosterone so as to make that pelvic exam less painful for these individuals, because there can be a lot of inflammation and atrophy, as I said. The other thing that you should know is, and just be reminded that just because someone has become trans male, if they still have a uterus and they still have cervix and vagina, they're still at risk for all the issues that non-trans individuals have. So we need to always be aggressive within the reason, within the acceptance of the patient as to doing preventative tests. And so you want to talk to them and make them feel comfortable. That means that you may not get to do the full exam on that first visit. Normally when we schedule a history and physical, everything gets done on day one. But in this case, if you don't have a relationship yet with that individual, you may want to break it up. So you do the history, you may do some of the physical exam, and then offer the opportunity to the patient to do the more sensitive physical exam portion at a follow-up visit. And they may want to have someone present to make them feel comfortable.
Well, that's great. I was wondering how long of a visit this would be, right? But from everything that you're talking about, from the history and then the physical, I'm going to say that it is providing the LGBTQ plus community really great care. You're really spending a lot of time with these patients.
I agree. It may be a little bit more than the average visit, but I think part of it has to do with it's under the assumption that this is a new patient, and it's a new patient with some unique issues. So you're absolutely right. It probably will be a more extended time period. I'm not sure if the follow-up visits would be as proportionately extended, but this is the opportunity to create trust and to become familiar with the patient, because remember, patients are going to be along the spectrum, especially if they're getting gender-affirming therapy. So it's not black and white. There's a gray, and you want to know where they are in this progression from one to the other.
Yeah, I think that makes a lot of sense. You spend a little bit extra time on the initial visit, so you really get to know the patient, not only their history and their, maybe their physical exam, but actually know the patient, who they are as an individual. And then not only are you taking care of them, but you're also building trust and like fostering a nice relationship with that patient. So I like that idea on, the initial visit, you spend a little extra time to just kind of formulate a good plan going forward, right?
Correct. And uh, if we had to talk about again the barriers in this physical exam history part, just remember if they're on any sort of gender affirming therapy, that can interact with the medications they're taking. So that's part of your very thorough history, right? That includes a medication history. But most EHRs have medication interaction as well as medication diagnosis interactions. So that can guide you so you can be aware that whatever medication you give does not interfere with the current goals of that patient, especially if it has to do with hormonal therapy. You should bear in mind that women and transgender men, as I alluded to, have certain issues. So women are at increased risk of breast cancer if they never became pregnant or have never taken an oral contraceptive pill. Women are at increased risk for cervical cancer. And there are a couple of reasons. One would be they might feel that a PAP is unnecessary if they're not having sexual relations with a man. That does not mean they don't need a PAP smear, and they need to be educated of that. PAP smears, as I said, on transgender men can lead to an unsatisfactory result, as I alluded to. And again, this has to do with the duration of testosterone treatment. So you need to keep that in mind. Feminizing hormones can increase the risk of cardiovascular events and thrombosis. And again, just remember, as you would with men, transgender women are still at risk for prostate cancer. And transgender women who normally, like all members in the trans community, who are not getting frequent access to good primary care and preventative care, are at increased risk because if they're not getting screened, their likelihood of getting cancer goes up. And I believe a recent article was published that said one of the leading risk factors for prostate cancer progression and morbidity was just never being screened, which makes a lot of sense, but it's something that people need to be reminded of.
Yes, definitely. So when you're treating this patient population, what do you recommend for connecting patients to services within the community? And maybe just, you could talk about services within your area, or if you know of any throughout the state.
Sure. I mean, we're very lucky. Here on Staten Island, I'm sure in many other communities, there are many community-based organizations. The question is, how do you find them? How do you learn about them? Well, you could easily do a query on your search engine of choice, which for most people begins with the letter G. And these community-based organizations can provide training, as I said before, in person-centered care, as well as LGBT care for your staff, but they also are very supportive of the population. As I mentioned before, your social care network, which went into effect in January of this year, may have resources that are available for your staff as well as your patients. When I was president of the local county medical society, I encouraged these CBOs and others to provide lectures to our physicians. And I invited them to staff dinners and to provide tables where they could provide literature and create relationships with the providers. And by doing that, we raise the awareness of the physicians and encourage collaboration. Collaboration is key. And as I think you alluded to, Tammie, we want to be able to feel that as providers, if we can't provide a service or if there's someone who could do something better in terms of providing some sort of supportive assistance, let's reach out to them. And many of these are, again, community-based organizations not-for-profits who really put the interests of the LGBTQ plus community at the forefront.
Okay. Now, I know we covered some of this in the prior questions, but what are some potential barriers to treating this patient population?
I'd like to switch, since we already spoke about some of the risks related to hormonal therapy and any sort of surgical therapy, and I want to go towards a topic that sometimes providers feel uncomfortable talking about, and that has to do with sexually transmitted infections. These are often initially asymptomatic, and often people are not being screened. We want to emphasize the value of condoms. Just in terms of epidemiology, there's an increased prevalence in individuals who have sex with men, so men having sex with men, transgender women, or sex workers, of engaging in either anal sex, because you should know that the rectal mucosa makes it easier for the transmission of these infectious materials. Having multiple sex partners just increases the likelihood of an infection because just through a sheer number of exposures, and also just the generic barriers to healthcare that I mentioned. People not feeling comfortable going to a healthcare provider, or not being able to find a healthcare provider who is not supportive. So there's the risk from exposure, but there's also the risk of not getting the care or feeling that you can get the care. And that's why I think it's wonderful that we're doing presentations like this, and other organizations are doing it, because as providers, we need to be welcoming and let them know that they can come to us. And what we can't take care of course, as with anything else, we might refer out. But in general, there's a lot of things we can do. And I mentioned just in terms of getting a good history, doing a physical. But let's now focus on the sexually transmitted infections. Just as a reminder, men who have sex with men or multiple sex partners are at increased risk for hepatitis A, B, and C. Well, the good news is we do have vaccinations for A and B. B is curable. But if you don't screen for it, you can't treat it. And if you don't give the vaccinations, you can't prevent it. Something to remember with HIV is, again, increased prevalence, men having sex with men or multiple sex partners. You should be aware of prophylaxis after exposure to someone who might have HIV, and prophylaxis before. You should know that there's a screening test. It's a fourth generation antigen antibody test, which is a gold standard, and it's an at-home oral swab, which is a screening test. There's a fourth generation antigen antibody test, which is a gold standard. There is also an at-home oral swab test, which is an antibody test. It's cheaper, definitely more convenient, but a little less accurate. There's been a big push in my community, and I'm sure in your communities, for HPV vaccination. And generally it's been promoted among the pediatric physician population. But you should bear in mind, again, HPV is more likely to occur if populations have men having sex with men, or again, multiple sex partners. It's a recurring theme, like I think you're picking up at this point. Most of us might know that HPV vaccination is available between the ages of 9 and 26. What some of us may not know is that vaccination is also available between the ages of 27 and 45 on a case-by-case basis, depending on such factors as a sexual history or other risk factors. Tammie and I were having a discussion before we began the podcast, and she reminded me of the actor Michael Douglas, and he's not the only individual, but many prominent individuals have come out and talked about their HPV-related cancers, which they felt came from sexual exposures. So we want to remember to offer this vaccination to people over the age of 26 if they're at risk. There's also an initiative called the Last Mile Initiative, where individuals can do their own self-testing, but it has to be done in a healthcare facility. But if an individual didn't feel comfortable with their healthcare provider doing the HPV screening, they could go either in a bathroom or again stay in the exam room and do the screening themselves. The accuracy, I believe, is a little lower, not the same, but it's important to offer them that option if they decline being tested by the healthcare provider. A couple of years ago in 2022, there was a small outbreak of Mpox, previously called monkeypox. This outbreak was in the Clade 2 environment, CLADE. This variant had a lower rate of transmissibility, fortunately. In the Democratic Republic of the Congo, Clade 1 is more prominent, higher rate of transmissibility. What was offered at the time was the JYN NEOS vaccine. 2 doses are needed. And again, where clinically indicated, vaccination made sense, but this is yet another type of infection that most primary care doctors were not familiar with. Syphilis, which has been around since time immemorial, has made a great resurgence. I put the word great in air quotes. It's known as the great imitator, so it can appear as almost anything. Dermatological, neurological. And so you need to keep that in mind. There's been an 80% increase in syphilis between 2018 and 2022. And this is due, unfortunately, to people feeling more comfortable. And when I say they feel more comfortable, is now that we have prophylaxis before exposure to HIV, prophylaxis after exposure to HIV, individuals aren't using condoms. Not using condoms obviously increases their risk of exposure and keeps them from having access to this barrier, which will, of course, not just reduce their risk of syphilis, but other STIs. You should remember that penicillin G is available as well as doxy-PEP. The efficacy for these 2 antibiotics is up to 79%. Other screenings recommended by the CDC include chlamydia, and there's a doxy-PEP for this. We spoke about syphilis, doxy-PEP. Gonorrhea, doxy-PEP. Efficacy in this case is only 51%, but it's just something to remember. And remember, you need to screen for herpes as well as trichomonas. PrEP is best used on a daily basis. And there's also a non-FDA approved on-demand option, which isn't as efficacious, but may be considered by some healthcare providers. So it's important to tell them that pre-exposure prophylaxis is best if it's taken on a daily basis, but there is an on-demand version, which is off-label, if for some reason they could not take the daily medication. Post-exposure prophylaxis has to be given within 72 hours, and it's a 28-day course, and then depending on their history and response to the medication, you would then proceed to pre-exposure prophylaxis if their risk continued based on their sexual history.
Okay, great. That again was a lot of really good information. And I know we talked about some of this before the podcast, but it was really, I don't think a lot of people know about the HPV vaccine being available to individuals up to the age of 26, but then in those case-by-case basis in the at-risk population up to the age of, I think you said 45 or maybe 46. So, I mean, that is a lot. That's something good for our providers, but also the community to know. And I did not know that there was an at-home swab screening for HIV. How long has that been available?
I think it's relatively recent in terms of the most recent generation of that test. But again, it was the idea of making it available to as many people as possible. And again, they keep improving on it, so the most recent one is relatively fresh. It's just not as sensitive as doing the antigen antibody test. This one's only an antibody test.
All right. Thank you for sharing that with us. Now, before we say goodbye, do you have any advice for healthcare providers who are new to practice or just thinking about treating the LGBTQ plus population?
I'll go back to the fundamentals. You need to create trust. Trust takes time. trust requires an environment. So the signage as a person's walking into your office, again, that rainbow flag may not mean something to many people, but it will mean something to the LGBTQ plus population. One of the key points here in terms of trying to make the relationship better is the same stuff that you would do with anyone, and that is create a trusting environment. And that is not just for you as the healthcare provider, but also from your staff. So definitely get your staff trained. It'll be good for them to understand what the patients are experiencing on the way in, because they may be able to identify with many patients, but they may not be able to identify with what the LGBTQ population is going through. And, just having a flag near your front door may not mean anything to most people, but means a lot to the individuals from this community. And time, don't rush it. We talked about these initial visits may take more time than you commonly do, but this is the best investment you can have for this relationship. The more time you spend, the more trust there'll be, the more open any of your patients will be. We all know this, right? If there's a rushed visit, we may not get everything we need to know. And William Osler said this almost 140 years now. If you just give a patient a chance to talk, they'll give you the diagnosis. But if we cut them off, all the tests in the world may not give you the answer that you need. And with that, I'll just say thank you for this opportunity to talk about this subject. It's very important to me, and I know it's important to you, and I'm sure it's important to the listeners.
Yes, thank you, Dr. Volpe. I really enjoyed this conversation. It was a lot of great information, very important and pertinent. And as I mentioned earlier, we're going to provide a lot of links to the statistics and to some resources that Dr. Volpe recommended. So that will be in the notes for the podcast. And thanks, Dr. Volpe. I hope you come on the podcast again soon.
Looking forward to it, Tammie, and thank you for your wonderful assistance. Looking forward to collaborating in the future. Thank you, everybody.
And that's the verdict on creating a welcoming environment for your LGBTQ plus population. Thanks everyone for joining us today. I hope you enjoyed this very informative podcast. Stay connected with us on Facebook, Instagram, LinkedIn, and X for updates on our next podcast. This podcast is for general purposes only and should not be construed as medical or legal advice. This podcast is not comprehensive and does not cover all possible factual circumstances. Because the facts applicable to your situation may vary, or the laws applicable in your jurisdiction may differ, please contact your attorney or other professional advisors for any questions related to legal, medical, or professional obligations, the applicable state or federal laws, or other professional questions.